First of all, I congratulate Dr. Sandeep Jasuja for well-drafted agenda for head and neck cancer. And I also say good evening to my chairpersons and all the seniors and colleagues who are there. And now I start. This is the abstract which was presented in ESMO 2022. That is Nivolumab plus ipilimumab versus extreme regimen as first-line treatment for recurrent metastatic squamous cell carcinoma of head and neck. So the reason is क्यों head and neck IO से पीछे रहे? सबको IO मिला है तो head and neck क्यों रहे? Let's see. So we know that head and neck cancer, even being a capital, we said the word early, the capital of word for the head and neck cancer, but still we cannot find the logical treatment or the well-drafted treatment. And the head and neck cancer patients have poor survival in after the stage 3 onwards, recurrent and metastatic. The treatment options in recurrent metastatic are IO plus metronomic chemotherapy, then IO plus combination of chemotherapy or single agent, or the extreme regimen. So now the IO and AO is the option for the patients with checkmate 651 tried to bring who cannot tolerate the chemotherapy in first line. So key eligibility criteria for this study was patient in first line for the recurrent metastatic squamous cell carcinoma of head and neck. The subdivision will be oral cavity, oropharynx, hypopharynx, or larynx. Performance status must be good, PS01. Prior chemotherapy allowed if it was more than 6 months old. The data was stratified, results were stratified according to the E16 overexpression, E16 positive or negative, tumor PD-L1 status, and prior chemotherapy, yes or no. The patients were randomized into 1:1, Nivo 3 mg per kilogram every 2 weeks, and ipilimumab 1 mg per kilogram every 6 weeks. Extreme and versus the extreme regimen, as we know all, and until the disease progression or unexpected sectorial toxicity, or the 2 years were the upper limit for the IO plus IO. Primary endpoints independently tested: overall survival in all randomized patients, or the overall survival in PD-L1 patients with a combined positivity score 20 or more than 20. Other, if the more than 20 it is positive, then tested in the PD-L1 more than 1, and then progression-free survival, overall response rate, duration of response, and exploratory endpoints were progression-free survival, overall response, and duration of response in PD-L1 and PD-L1 CPS 1 or more than 1, patient-reported outcomes, and safety. So as we tell, OS, the statistical testing hierarchy was there, but tested all randomized patients and CPS 20 or more than 20 population were tested in parallel with equal overall alpha error of 0.025, two-sided error, using the stratified log rank test. Overall survival in CPS 1 or more than 1 was to be tested if it was positive in CPS 20 or more than 20. If OS in all randomized patient was positive, then OS in CPS 20 or more than 20 could be retested with overall alpha it is increasing to the 0.05. If overall survival in CPS 20 or more than 20 and CPS 1 or more than 1 were both positive, but OS in all randomized patients failed, then OS in all randomized could be retested with increasing the alpha error to 0.05. The patient's baseline characteristics were well matched. It was around median age was 60 years in both the arm, either it is CPS 20 or more than 20 or all the randomized patients. Performance status good. The most of the patients were from the oropharynx. It was around 40%, and P16 was positive in around 20% of the patients. Tumor PD-L1 expression was 60% patients were positive in all randomized, and the PD-L1 CPS 20 or more than 20 was observed in around 40% of the patients who were randomized Nivo plus EP versus extreme regimen. This was the treatment disposition or the algorithm and subsequent therapies. 947 patients randomized, Nivo plus EP 472 allocated, 468 received treatment, and 8% completed maximum 2 years of treatment. That means they were continued to have the response. Versus the extreme, the 475 patients were allocated and 441 received the treatment. In the Nivo EP arm, 54% patients had the subsequent therapy, while in extreme arm, it was 63%. And in Nivo EP arm, 49% any systemic, 8% immunotherapy, 42% platinum-based chemotherapy, and 16% radiotherapy. In extreme arm, 46% patient received subsequently immunotherapy. So this was the game changer that was not there at the time of extreme regimen. When it came into the picture, immunotherapy was not available as a subsequent line. Primary endpoints, overall survival with Nivo plus EP versus extreme regimen. It was failed to show the benefit in all randomized patients and 13.9 versus 13.5 months. But in CPS 20 or more than 20, it was quite impressive, crossing the control trial, historical control 17.6, maximum till now. And in extreme arm, it is also the 14.6, which was reported at the time of extreme trial. It is higher than that. This is the characteristics of the immunotherapy slide. This slide is the characteristic of immunotherapy, where you cannot find if you are giving immunotherapy. PFS is you can find hardly in any patient in any tumor. But yes, duration of response will be greater in immunotherapy arm if the patients are responding. Yes, the overall response rate is always poor in immunotherapy patients across all the tumors. And this happened in this trial also. Around 24% patient responded versus 37% in extreme trial. Although in control trial, historical control, it was around 59% in extreme arm. But in this trial, they showed only the 37%. In PDL1, CPS 1 or more than 1 population, median OS was slightly higher, only 15.7 versus 13.2 months, with a hazard ratio of 0.82. Median PFS was lower than the control arm, and overall response rate was also lower with the 28% versus 36. But again, the median duration of response was 18.3 months versus 6 months in the extreme arm. In the subgroup analysis, also, we can see that we discussed in the last slides. Yes, I found the one biomarker in this slide is the P16 positive, where the immunotherapy failed to show the benefit. But yes, extreme regimen showed the benefit. Yeah, I tried to find out in the keynote 48 also, but I could not find that slide that what was the response in the P16 positive tumors. So it may be a marker for the immunotherapy, but I'm not in position to comment. Patient reported outcomes, time to symptom deterioration was better in the Nivo plus EP arm, and overall self-related health status was also better than the extreme regimen. Safety and exposure, treatment-related adverse events were lower in the Nivo plus EP arm versus the extreme arm, and the grade 3 events were also more in the extreme arm than the Nivo plus EP. Yes, immune-related adverse events observed in quite high number, around 16%, although it was not grade 3, but yes, there was hypothyroidism was quite observed around 16% patients we can see here. And on the other are the most pneumonitis, which is usually most troublesome, it was only the 1%. So to summarize this abstract, in Checkmate 651, there was no statistically improvement in overall survival with Nivo plus EP versus extreme in all randomized as first-line treatment of recurrent metastatic squamous cell carcinoma of head and neck. Overall survival in the extreme control arm was better than expected based on the historical data. But the reason we may find that in this trial, 46% patients received the subsequently immunotherapy, which was not available at that time. In patients with PDL1, CPS 20 or more than 20, or CPS 1 or more than 1, Nivo plus EP showed evidence of clinical benefit versus extreme, as seen with the prolonged overall survival and duration of responses. Median overall survival 17.6 versus 14.6 in CPS 20 and 15.7 versus 13.2 in the CPS 1 to 19. With Nivo plus EP, more than half of the responders were still in response at 18 months in both the populations. Nivo plus EP tended to delay the symptom deterioration and clinically improved overall health status versus extreme in the CPS 20 or more than 20 population. Nivo plus EP had a favorable safety profile versus extreme and no new safety signal